Hi, everybody. Welcome back to FNP II, Nursing 670. I'm so glad to have you guys all back. It's going to be a great semester. I just wanted to go over a few things before we get into our first lecture for this week. Just make sure you review the syllabus, please. It's pretty similar to last semester in terms of the requirements and the assignments. The one big thing that's changed that I want to make sure that you are all aware of is that now we have a new web browser called Respondus in place that will be utilized when you take your exams. So it's a sort of intelligence that just monitors students when they're taking online exams, just to ensure there's no cheating or anything of that nature. Please refer to your syllabus regarding information and you need to take a dry run. We would highly encourage you guys to take a dry run, basically like a pretend little quiz with using the web browser, just to make sure you're comfortable with it and you understand how it works in terms of the placement of your camera and what the expectations are when you're taking the exam. I know some of you guys may not be 100% comfortable with it because it does film you while you're taking the exam, but we did feel it was important to give you guys kind of a real life example of what to expect when you do have to take your certification exam, when you take your boards, where you do have a very similar type browser system set up there with Respondus, as well as people actually watching you while you're taking your exam. It's very, very, it's got a lot of security when you go into the building to take your exam. So we just kind of want to give you a synopsis of how it's actually going to be in real life. Okay. So office hours this semester, I'm going to try to set up for every Thursday from 3 to 6. That may change weekly just because I am in clinicals every single day doing rounds, and sometimes they do run over. So I will post my anticipated clinical hours on a weekly basis, but I do want to have some time that I am available, that if you just want to jump on a call with me to review something, I am available for that. Feel free to email me if you have questions. Again, this is an advanced practice class. You are graduate students at this point. So if I can direct you to, to direct you to find whatever it is you need, or to give you resources to figure out, to help you figure out what it is you need help with, I'm very, very happy to do that. All right, so this module this week, we are focusing on Chapter 2, Chapter 5, Chapter 79, and Chapter 82. I'm going to break the PowerPoint up into two sections. This first section, we're going to do Chapter 2 and Chapter 5. Chapter 2 is based around caring and the caring process. And this isn't just for the APRN in terms of caring for your patient. This is also caring for yourself as well. We are going to get into self-care this first class. Because as you guys, I'm sure, have all been, experienced in your own clinicals, the burnout rate right now among all healthcare professionals is extremely high. So one of the things we definitely need to make sure is that as nurse practitioners, we are providing ourselves with self-care, as well as promoting and advocating for that for all of your patients and your colleagues. Okay, so we will get into that. All right, so in terms of setting you up for studying and reviewing, and the best way to grasp this content, definitely utilize your books, guys. This book is a great resource. I would also encourage you, if you haven't already, to purchase review books for your boards. I personally, my favorite is the Leak Family NP Intensive Review. This is one of my favorite books that I used when I was in grad school. I had it from the very beginning. Sometimes I would just go in there to look up more broad subject matters to see if I could get more of a synopsis, kind of like Cliff Notes, and then take it from there in terms of really grasping bigger concepts. So I found it really helpful, as well as, of course, the review questions in the Leak book are wonderful. One of my professors actually recommends Leak over Fitzgerald. There are two different big review books that are out there in case you wanted to just look that up. Fitzgerald and Leak are the two big ones in terms of reviews. One of my professors had mentioned to me that Leak review tends to be a really good review for people who speak English as a second language. Somehow she breaks things down very simply. So it's extremely helpful sometimes for people who, English isn't your primary language. So that's just a tidbit. If you wanted to get those books now, I think it will help not only for this coursework, but all of your courses going forward, especially for your clinical work too. You can always use that as a reference. It's a great reference book for sure. All right, so let's get started. We're going to start with chapter 2, caring, and the advanced practice nurse. Okay. So the first thing we want to talk about is just caring in general. What does it mean? What is it? Let me see if I can just hide this guy. Sorry. There we go. Okay. So caring is the essence of being human. Obviously, nursing is a deeply human relationship that you will develop with your patients as you continue on in your practice going forward. So obviously, the essence of nursing is caring. When you're talking about caring, I definitely would reflect on, why exactly you decided to become a nurse practitioner or a nurse in general. Like, what was your initial reason for taking on this profession? Was it a calling? Is it because you deeply care about people? Definitely consider that when you're listening to this lecture as we go on, because it's not just about caring and having this calling for your patients. It's also about caring for yourself as well, because remember, the care you provide to your patients is very much reflected in the care that you provide for yourself. And people do look at that when they are listening to their practitioner. So caring expressed in nursing, including advanced practice nursing, is the intentional and authentic presence of the nurse with another who is recognized as a person who's living and caring and growing in caring. So that's a beautiful, fancy way of saying, the nurse is there and she's providing this authentic and intentional care to care. And then the person who is receiving it is also, living and caring and growing in her caring nature. So it's a circular, caring is circular in nature for both the person, the practitioner, and the patient, and it goes hand in hand. All human service disciplines are based on caring. However, nursing is unique in that caring is what most directly characterizes nursing's knowledge base and service. So an example of this that I would like to point out that I've witnessed in my own practice in terms of nursing and caring, nurses tend to spend more time at the bedside. That we already are, we know just from practice in general. But the thing I found, with expectations as an APRN, you have to move more quickly. You have less time to assess your patients. So there's this concept, like when you go to the doctor, you get like 5 to 10 minutes in your visit if it's just a routine follow-up, or 15 minutes max. And then you get more time if it's a full physical assessment. But the thing I find now that I'm doing rounds as an APRN versus an RN is I have even less time to spend with the patient and more focused time on whatever it is I'm dealing with at the bedside. So it's almost like you forget to even say hello to the patient. You're honed in on what you're looking at, and then you shout orders to your nurse, and then you keep moving. Because when you have to see 30 or 40 or even sometimes 50 patients a day, which is what I'm seeing, you don't have really time to be, nice and caring and have all of this, kind of side talk at the bedside, which is so important. And one of the things that I find that I'm doing now in my practice is that I have reevaluated that, because I never signed up to be that practitioner that just walks in and out, doesn't even get to say hello to their patient because they have to get to the next one. So I actually have sat down with my company that I practice with, and I've actually pointed out to them that I need to slow it down so that I do have that moment to actually care for my patient. So just keep that in mind as you're going through your clinical practice. See how your own clinicians or preceptors that you're working with take time to really show their patients how they care. And also consider when you're working with your preceptors, what do your preceptors do for their self-care? You want to try to talk to your colleagues and see what they're doing for their own self-care needs. Medicine. In medicine, the fundamental commitment to caring is directly characterized in the diagnosis and treatment of human structural and functional problems, usually characterized in physical terms. So yes, we know this. This is why we are in this business, to help diagnose and prescribe, to help people get better, right? So caring is the matrix of the APRN. This, just as we said before, the stuff, quote unquote, within which the APRN patient relationship is brought to life. So the whole reason you became an APRN, right, essentially is because you care about human beings. So knowing another as a caring person requires a commitment to entering into the world of the nurse with the explicit intention of knowing that person individually and uniquely. So the bottom line is, as an APRN, you're developing a relationship with a patient. You're taking the time out to really understand where they're coming from and what exactly their goals are in their care. You have to really approach these patients on an individual basis. Everybody's needs and desires are different, and you always want to be open-minded and have options available for that patient, just to really make sure you're meeting their goals. As an APRN in practice, you're drawing on and transforming characteristic medical ways of practice for nursing purposes, right? And you're using specialized opportunities for creating situations of care that call forth specialized patterns of caring. So really what that means is you're using your basic knowledge base as an APRN, and then you're trying to find creative ways of using that knowledge and coming up with ways and opportunities that will, again, continue to bring forth the best care for your patient. Generalized patterns of caring as delineated in the Circle of Caring model include courage, authentic presence, advocacy, knowing, commitment, and patience. So these are all characteristics as an APRN that you want to make sure you're utilizing in your daily practice to really bring out the best outcomes for your patient. It does take courage as an APRN to really stand up for your patient, despite the fact that you may not even agree with what they want for their care. If that's what the patient wants, remember, we are patient advocates to start. So that is where our advocacy lies. And that is where we develop the courage and the commitment and the patience to advocate for our patients for the best care possible. Courage is a human act, daily application of values. So again, reinforcing every day, like, what am I doing here for this patient? What does this patient want? And am I doing the best that I can do to provide for this patient? Breaking down these different particular patterns of caring, and including courage, is really a way to just solidify them in your own practice. So having courage offers an ethical grounding for your practice, and courage manifests itself in making one's nursing vocation a commitment to these values and beliefs that undergird caring. An authentic presence includes intentionally being with another in the fullness of one's personhood, and making sure that your caring is communicated through your authentic presence by initiating and sustaining a medium of nursing within the nursing situation. So having an authentic presence means that that patient is not going to forget you when you walk out of the room. And how do you make that presence, authentic? How do you make your presence authentic? Is definitely by obviously initiating and sustaining whatever it is that you're trying to do. So that includes, you come up with a solution to a problem with your patient, and now you're going to follow up with them, and you're going to follow up later on to let them know the outcome. This is how you initiate and sustain, your presence with a patient. Starting and then follow up is really key. That definitely would show a patient that you care. So advocacy, another important pattern in caring. So advocacy is definitely the most traditional way and a nurse practitioner can express caring. Gadow came up with something called existential advocacy. And here they summarized it by saying the self is brought into the situation as a full partner. Basically, that means that the self is brought into the situation by you will come into a situation and you would share alternative perspectives for consideration with your patient, although not insisting on them or imposing on the patient and making them feel like, you're giving them this other consideration or option and you're going to make them feel bad if they don't take it. No, that's not what you're doing. You're just giving them other options and giving them more an education as to what they have available to them in their healthcare plan. When the nurse offers existential advocacy, the nurse feels truly known, respected, and connected in a way that affirms humanity and being. Well, of course, so the patient is going to feel very respected and connected to this person when they realize that the nurse practitioner is giving them another avenue out, or a better avenue in terms of their healthcare. So, of course, they're going to feel better. They're going to feel um, cared for, more respected, and connected to this nurse practitioner. And again, by providing this existential advocacy, you're also creating an authentic presence that hopefully your patient will not forget, and they'll want to return to you as their practitioner. So knowing, another important thing to have in terms of caring. So knowing that and knowing about refer to descriptions and analysis of the patient situation in the context of facts and information, which are empiric data points, okay? Knowing directly implies being deeply attuned, which comes through intentional and authentic presence. So when we, knowing directly, we're going to get more into talking about aesthetic knowing as we go forward. So patterns of knowing as described in nursing literature by Carper include empirical, ethical, aesthetic, and personal knowing. So let's talk about this. So we know we have our intuition, right? So a lot of this comes from an intuitive sense, but what exactly, how do we break that down? So some of it comes from your intuition, but some of it comes from empiric knowledge, like drawing on science and skilled observation. So what you learn in class, okay? And then you have your ethical knowing, which is prompted by your values and your morals in situations. And then you have your aesthetic knowing, which is an incorporation of knowing into a situation for integrated understanding with the nurse. So aesthetic knowing is more understood like when nurses understand a deep meaning in a situation. So you're looking at this, the situation that you're in, and you're not getting all mixed up with all the little details of the situation. You're looking at it from a bigger perspective. You're taking a step back and saying, okay, what's really going on here? And as you advance in your practice, this level of knowing will continue to grow. So as you start to grasp these meanings, you can then draw from these meanings with your inner intuitive knowledge, and then your creative abilities will respond to the situation that will help facilitate change and increase growth for both yourself and your patient. So commitment, another important quality of caring. So choosing to be a member of the discipline and profession of nursing speaks to a lifelong commitment of service to humankind. So keep in mind, guys, you know, you're called to the table, you're doing this profession, the advanced practice nurse. Not only is it a privilege, it's an honor to do this. Like, we are committing to a service that will help all of humankind. I mean, that's tremendous when you think about it. And, you know, when you graduate and you take your boards and you finally get your license to practice, you're going to be so humbled, you know, especially on your first few days of work, when you realize the level of expertise that's required, as well as, you know, the sudden responsibility that you now have in your hands. It's a big honor, and it's a big obligation, and it's a big commitment to take on this role. So yes, if you didn't care, believe me, you would not be going through what you're going through now. So commitment directs obligation, or what ought to be in a particular situation. So, I mean, that makes sense. You know, you're committed to doing the right thing. So obviously you're always going to try to do the right thing in any situation. And commitment should not be experienced as a burden, but as a response that is right, conscious, and caring. So challenges to commitment. So what could be challenging to your APRN practice? So some of the challenges that are definitely coming up, especially as of recent, are obviously burnout, specifically from loss of staff and you know, increased acuity of patients as of recent. And then other factors that also could be challenges to our commitment would be obviously economically driven care, which might conflict with calls for nursing from patients. And then, of course, the APRN has the unique opportunity to demonstrate how a commitment to values of nursing influences the outcomes of care. So, of course, it's our role to advocate when we start to see that there's shifts going on in the healthcare system, especially if they're economically driven. How do we as APRN step up to the plate and say, hey, this is blood money. We're not doing this, because this is not in the best interest of our patients and the outcomes of their care. So those are things you always want to look at when you're in your practice. Even myself, I recently had to come to have a meeting with my company that I work with, because I was finding that economically, what we were doing was probably not in the best interest of both our patients, but also in terms of what my standards of care dictate for me from my ethical, moral, and just commitment to this profession. So, as an advanced practicing nurse, you are going to be definitely more challenged than you are as an RN, because your role is independent at times, and you really have to be very careful what you allow yourself to get into within your standards of care. So nursing as human science. It always occurs in relational contexts, of course. It calls for continued commitment to understand better the lived experience of the nursed, to truly hear their stories, and to respond in ways that matter, ways that nurture and sustain persons as they live and grow in caring. So obviously things are going to always vary depending on the situation of your patients. But no matter what the situation is, you always want to try to do your best. Listen to your patients, hear what they have to say, and see how you can just help make their days better. You want to have a lot of patience. We all know as nurses, and especially as advanced practicing nurses, you have to have a lot of patience, not only with your patients, but with your colleagues as well, and the nursing staff that will be working kind of under you, that you will be giving orders to and education to. Sometimes, they don't measure up in terms of what your expectations of their scope of practice is. So you just want to have a lot of patience and just be kind and just as gentle as you can with everybody you're working with, because things are very tough as it is in the healthcare industry. So we want to not make things even more difficult with our presence. So, when it comes to patients, this is where you want to allow and trust that people will grow in their own time, in their own way. It's not a passive attribute. It's an active openness to the moment, alive with possibilities. So that's a nice way of looking at what patience is as a caring attribute. It's not that you're being passive. You're just being open to allowing people to grow in their own time. Okay. You want to have a lot of humility and courage, which are intimately linked to patience, because you need to have the courage to let someone be, and the freedom of choice. Again, this comes back to advocating for patients, for their own needs, and for what works best in their plan of care. Even though what you may think may be best for them, if that's not what they truly want and will really make them happy in their freedom of choice, then you really have to make sure you reevaluate what your goals are for the patient. Okay, so nursing situations. So going in the next few slides, I want you to consider what we're about to talk about in terms of applying these particular things to your clinical reflections and your journals, whether you write it in any of those or even in your Typhon logs, whatever it is. I want you to really look at these slides in terms of that. So we're looking at different nursing situations that help just keep you grounded in terms of for instance, practice stories, which would allow you, the student, to uncover the knowledge, skills, and practices most relevant to advanced nursing practice. So in terms of practice stories, some of those are listed in your text, in your books. You'll hear like clinical implications. Those are things you definitely want to be paying attention to. Listen to any of the stories from either your professors or your fellow colleagues, just to help give you some more knowledge to apply to a situation that you may find later on in practice. Okay, so calls for nursing. So things to always consider in terms of bringing a better quality of care to your patient. So what does your patient need right now? That's something you're going to ask yourself. And what do you as an APRN bring to the situation? You develop advanced practice sensitivity and expertise in hearing calls through intention, reflection, experience, and study. So obviously, guys, when you're listening to, senior APRNs, people at your workplace, like definitely listen to what they're telling you, and reflect on their reflection. See if you can learn from their experience. You don't want to be making the same mistakes other people make. You want to learn from other people's mistakes and then try not to make the same mistakes, right? So caring process includes illustrations of how advanced nursing practice is truly an expression of the caring process. So I don't know if you guys read that little story on page 22, which is one of those clinical stories, like how to apply what they're telling you to clinical practice. But she talked about the nursing situation was called Like a Pebble in the Pond. And it was pretty basic. It was basically, she talked about how a patient had come in with her daughter, and the daughter had been going to multiple caregivers, and nobody could seem to give them a clear diagnosis or steer them in the right direction in terms of a plan of care that would actually be effective for her. So she kept going to random practitioners. And finally, this nurse practitioner realized the patient was having some respiratory issues that likely needed pulmonary consult. So she went ahead and made that consult, and lo and behold,
It's 4
she
o'clock.
ran into the same patient and her daughter, sometime later. And it just so happened that, they were eternally grateful because now finally they have some quality of life where she doesn't feel like she's consistently sick again. So the bottom line with this story is, you don't even realize the smallest little thing you could do as an APRN and the impact it may have. Right now in healthcare, I'm finding there's so much poor lack of follow-up. People are discharged and nobody knows who the surgeon is. Nobody knows when they had the surgery. Nobody knows who to refer back to. Like there's all these things that are just missing and that are getting forgotten. So as an APRN, you kind of figure out your role now suddenly is just to, connect the dots just so this patient doesn't, lose out on their plan of care. And that's what I feel like a lot of the nurse practitioners, especially that I work with, have told me is that they're finding they're doing a lot of the follow-ups for other clinicians because patients are just getting lost in the system. So again, you're going to figure out what your niche is in your role, depending on where you work and what this type of place you work in, as to how you can be the pebble in the pond and really keep an authentic presence and commitment to your profession. And things to consider in your own primary care practice or clinical that you experience during the day. What do you feel like any experience that you can have witnessed where you've seen like a small thing become a very, very valuable thing in the plan of a patient's care, in a patient's care plan? Things to just consider. I want to give you guys some ideas, some material to use to reflect on so that you actually have some meat and potatoes for your reflective journals, not just so that you can keep them going, but also so you can use them as something that will really help give you some guidance going forward in your practice. Okay, so that's the end of the chapter 2 PowerPoint. We're going to move on to chapter 5, evidence-based practice. So let me just flip over to that. Hopefully you guys took your research course already, nursing research, because this really stems a lot from that, and it's really pretty much a review of that. So I'm going to go through this quickly, but a lot of this hopefully is review for most of you. So here we go. So chapter 5, evidence-based practice. So the first things I'm going to tell you is I would definitely encourage you to look in your book at page 59 at box 5.1, which is an excellent little tool to use in terms of looking at the key steps in implementing evidence-based practice, because you really need to know, how do we come up with this? Why do we need this? This is so important in your practice. I can't even stress that enough, like how important this is. So here we go. So evidence-based practice. So evidence originates from research findings, of course. Evidence-based practice decisions involve the clinician, a convincing body of evidence, patient preferences, and values. So why do we need evidence-based practice, guys? The bottom line is everything we do in our practice, all of the guidelines, techniques, reasons we do things is all based around evidence-based practice. Somebody figured out a way of doing something, decided to collect data to prove that whatever they were doing worked. They put it through a rigorous scientific methodology, and then they came up with a strategized, strategic presentation of why and how to utilize this data. That is basically what evidence-based practice is and how it is all put into place. Now, let's break it down into the real scientific nitty-gritty steps of how we develop evidence-based practice. So, aims of nursing research for clinical practice include systematic pursuit of knowledge to answer questions of importance. We want to generate understanding and validation of existing knowledge. We want to conduct studies to develop a body of nursing knowledge. Evidence-based practice is of gathering of information from published literature to make decisions about its application to clinical practice, and also to give you considerations about the evidence. So we use this evidence to gather a knowledge base as to how we're going to practice and implement our practices, okay? So keep in mind that as a nurse practitioner, you are upheld to evidence-based practice standard guidelines. That is why we keep talking about all these different guidelines and the different avenues and places where you go to find out your guidelines. All right, because when you're in practice, you need to know these guidelines because you need to make sure you're actually putting them into place for your particular patient. So let's get into a brief history of evidence-based practice. Its origins are traced back to somebody named Archie Cochrane, who encouraged the medical professions to establish a collection of RCTs to validate rigor of published research. So RCTs are your randomized controlled trials. Okay, guys, this guy, Archie Cochrane, was a Scottish epidemiologist, and he came up with this little system to make sure that anything that was published was actually went under this validated, rigorous collection of trials to make sure it was actually proven, valid. So it was first conceptualized by nursing as something called research utilization, or RU, and that was actually started back with Florence Nightingale, where she used data to improve the sanitary conditions, and she was the first one to come up with the idea of using data to prove something. So the research utilization model was, that's how it first was known, RU, and then it became the Stettler model, which is basically a method used to address the need to use nursing research findings in practice. So the Stettler model basically sets up, the validation of the information that was gathered and then puts it into practice in nursing. So there's a whole lot that goes on behind the evidence-based practice. And what I like to remind people is, so evidence-based practice is not something you just Google. It's not, that's the big thing. As nurse practitioners, we have now in our generation, we have such quick access to information on Google, but unfortunately, everything you're finding on Google is not evidence-based practice researched. So you have to be very conscientious about where you're finding your data, because sometimes when you're documenting, especially things that are new and just recently studied, and you're trying new things in terms of treatment, you need to make sure you're referencing where you're getting your evidence-based practice guidelines from and why you're utilizing them. And if you don't utilize it from a valid source, then you can be held liable. Okay, so that's why we just really teach the importance of evidence-based practice and information gathering and how it is gathered, so that you understand the level of research that goes into the information we're presenting to you. So how do we develop these best practice guidelines around evidence-based practice? So we have the traditional approach, where in common practice, you practice certain things because they're correct. And it was appropriate in the past because they didn't have as many diagnostic tests or interventions to actually study or prove any, wrong or right. So today's approach is very different in that everything is developed from scientific evidence. We have a scientific process that we use to make sure our evidence-based practice is valid. And from this framework, we have created these guidelines, and from there, we create practice. So the development of best practice guidelines is managed by the Agency for Healthcare Research and Quality, and they lead the way for evidence-based practice. The mission of AHRQ, or Agency for Healthcare Research and Quality, is to improve the quality, safety, efficiency, and effectiveness of healthcare for all Americans. They use guidelines, which are references for healthcare providers. They provide a framework for insurance utilization review, and they influence malpractice litigation outcomes. So again, I can't reiterate that enough. So just make sure you read that again. Evidence-based practice guidelines are used as a reference for healthcare providers, aka dictates our healthcare and our practice as nurse practitioners. It's also the framework for insurance utilization review. So what does that mean? That means that insurance companies use our evidence-based guidelines as a framework to reimburse us for our treatments and our practices. And of course, also these evidence-based practice guidelines also influence malpractice, because if the nurse practitioner does not measure up to the evidence-based guidelines and standards that are out there, then she can be held liable. So that's why we follow evidence-based practice guidelines. So how do we implement these AHRQ guidelines, or Agency for Healthcare Research and Quality guidelines? We have to overcome barriers. And how do we do that? So they have developed evidence-based practice centers, which are both private and public partnership, and they produce evidence on topics from providers. A lot of your professors will partake in these kind of studies, and it's just a lot of studies, a lot of research goes into the evidence for these guidelines. We also have the National Guideline Clearinghouse, which is an electronic repository for guidelines. So that's where it's all uploaded. And then you have research and evaluation activities to develop guidelines, implementation strategies, and outcome-based research. So in terms of applying clinical practice guidelines to clinical practice, obviously we want to practice our standards and guidelines. Standards relate to a framework for practice. They are inflexible, and they are intended for use in all circumstances. Guidelines focus on individual patient care and decisions, which provide a reference point and general direction for decision making. And they really only deviate from, you're only really to deviate from the guideline as long as you have a clear rationale for that particular patient. Keep in mind, you want to make sure you know what your practice standards and guidelines are for your particular practice. So the first thing you're going to find out is, where is that notebook? Where is that information when you first start practicing there? And you're going to want to review it so that you know, and everybody else in the practice knows, where to find information depending on whatever issue arises. In my company, our practice and guidelines are uploaded right onto our laptops so that we can pull it up anytime we're in the field if we have any questions. Okay, so practice standards are intended to be used under all circumstances and define correct overall practice. So the American Nurses Association has a certain set of standards that they practice with. And of course, practice guidelines are intended to provide a reference point and general direction for decision making. So, now you understand that we obviously practice with evidence-based practice. We have standards and we have guidelines. The bottom line is, you need to make sure you review your standards and guidelines, especially when it comes to a particular disease process, or in terms of primary care. Like, for instance, one of the things we talked about last semester was the United States Preventative Task Force, and that's that entity holds the guidelines and standards of practice in terms of age and what testing and health promotion activities need to take place at what time and what age. So again, these are all guidelines that you need to make sure you're aware of, review, and know where to find them. Okay, so the development of evidence-based practice guidelines and grading of evidence. So here are the essential elements that are incorporated into evidence-based practice guidelines. So we need to identify the topic. We need to figure out what panel of expertise is going to review it. We need to do a systematic review of the literature with the rating of the literature. And by rating of the literature, they mean how much validity is or evidence-based practice is within the literature itself. You want to do a development of evidence-based tables where you analyze the level of evidence within each study and what it's lacking and what it actually helped standardize and change. You want to do a draft of recommendations based on the evidence. So you want to come up with your own thought process and draft of what you would recommend based on the things that you've just reviewed, depending on what the situation is at hand for your particular standard. You want to do an external review of recommendations. You want to see what other people said about those recommendations. And then you want to finally decide if they are going to accept the revised recommendations or if they find that there's not enough evidence to back it up. So this is how the evidence-based practice guidelines and grading of evidence comes into play. Here is just a reminder of what evidence-based practice consists of. So what are we looking at? We're looking at the best research evidence. We're looking at clinical expertise, and we're looking at patient values. This is all what encompasses evidence-based practice. Here is how we are breaking down our evidence-based practice. So remember your hierarchy of evidence. And in this little triangle, it shows you your levels of evidence and how they fall on the hierarchy. The lowest levels have the least amount of evidence-based practice versus the highest have the most. So our meta-analysis and systematic reviews are our highest levels of evidence versus just background information and expert opinion is really doesn't give us much actual hardcore evidence. Here on the left, it shows the different sources of where you can find these types of studies. These are your different databases. Know these, so important. Some of your jobs or the organizations you work for will have access to these resources. UpToDate, Cochrane, PubMed, those are your best ones to go through and get your evidence-based practice studies and reviews. So those are the websites you want to make sure that you either have access to or know how to get access to. Right now, because you're in Goodwin, you have access to it through the library. Research designs for level 1 evidence. So level 1 is our highest. Remember, that's up here at the top. Here's our level 1, our meta-analysis and systematic reviews. So these are systematic review or meta-analysis of randomized control trials. These are our highest levels of evidence to base a change in practice. So when you see your systematic reviews or meta-analysis, you know you're in a good place in terms of getting good evidence to support your change. Searches all randomized control trials that address similar clinical questions. So that's what systematic reviews are. It compiles the studies and then puts them all together and then does an analysis of all the information put together. Cochrane Library is one of your best bets to get systematic reviews or meta-analysis. And that again is your level 1 evidence. This is appraised and filtered. It is your highest source of information. Okay, so then we have our level 2 evidence, which are single well-designed randomized control trials. These this level of evidence establishes the cause of a disease, the efficacy of a treatment or intervention. It maintains a high degree of control with experimental conditions. The randomized assignment allows for a high degree of confidence, and the double blinding further strengthens support for cause and effect relationships. So this is where we're at here. This is our level 3, randomized control trials. Level 2. Then we have our level 3, which are well-designed control trials without randomization, okay? So here we're evaluating the effectiveness of an intervention or treatment. Subjects are not randomly assigned, and here we attempt to improve internal validity with control of extraneous variables and standardization of treatment. So again, level 3 evidence is controlled trials without randomization. Okay. Remember, as we go lower on this pyramid, we get lower levels of evidence. As we go higher on the pyramid, we get higher levels of evidence. Okay, level 4 evidence are well-designed case control or cohort studies, which are useful for answering clinical questions related to prognosis or causation. It's compared those with the disease to those without the disease, including prior exposures or a course of disease observed without interference. And these also, level 4 evidence also includes observational studies. Okay, I like the pyramid. I think it puts these in perspective, so I always refer back to it. Level 4 also has risk introducing bias with no case control in the study, and is their most commonly used in the epidemiological design currently in literature. And then last but not least, oh, actually, this goes up to, oh yeah, we have a level 7. Okay, so level 5 evidence. So just so you know, some of your pyramids sometimes don't go up to level 7. They only go up to level 5. There are a lot of different versions of the hierarchy of evidence. What do you call those? Those hierarchy diagrams sometimes are vary in the actual amount of levels, but just know the most important thing to know is what your highest levels of evidence contain. So those are your systematic and your meta-analysis reviews. So level 5 evidence includes systematic reviews of descriptive or qualitative studies. In these studies, we portray characteristics of a population or clinical situation. It includes qualitative or quantitative, and remember, quantitative includes measurable characteristics versus qualitative includes understanding of the phenomena of the clinical question. And in terms of research designs for level 6 evidence, we're talking about single descriptive or qualitative study, which is mostly just case studies. It tends to give you a likelihood of decreased objectivity. And we utilize these to alert to an adverse event, and alert to a rare disease, or add to a provider's knowledge base. No inferences can be made to the general population from this level of evidence. So this is level 6. So it's down here. Okay, and then we have level 7 evidence, which is the opinion of authorities and or expert committees, which this follows the really basic traditional approach of evidence, may or not be based on strong evidence, should not be a sole determination of changing practice. It may be the only evidence in some rare situations. Like if there's a new and upcoming issue that's coming up, this may be all that there is. It's just somebody talking about what they've experienced, basically. Okay, so important, evaluation of clinical practice guidelines. So this is what you're asking when you have to go look something up and you're in the middle of a situation where you don't know something in terms of your patient's care. So when you find the information, you're going to read the information. You're going to say, who created this guideline? What date is the revision? Because remember, you don't want to look at any evidence-based clinical knowledge that's more than 5 years old. It's technically considered outdated information and not best practice if you're using information that is greater than 5 years old. There's too much information available to you out there that's less than 5 years old that you should be using. Okay, so again, who created the guideline? Is the information less than 5 years old? Is the guideline clinically important? How strong are the recommendations? How strong is the available evidence? How many people have actually proven that this is actually a thing? Okay, you really want to look at how strong is the available evidence? How much evidence is there? And then, is the guideline applicable to my patient? All right, is it actually appropriate for your patient's needs? So these are all evaluations of your guidelines that you want to question yourself when you're going through them. Okay. Evaluating the evidence to change practice. So it's critical to distinguish between intermediate and clinical outcomes before applying research findings to practice. So improvement in intermediate outcomes does not necessarily lead to improvements in clinical outcomes. So that's an interesting thought. Things that may you may find that in the moment may actually help your clinical outcomes may not actually be appropriate for the long-term research findings in terms of changing actual practices. So that's where it's important to really do your systematic review before we're actually applying these things to practice and changing guidelines. So for example, a use of an angiotensin enzyme, an ACE inhibitor in patients with congestive heart failure. So developing a point of care strategy, we want to ask a clinical question. So how are we coming up with just the idea of even applying evidence-based practice? How do we even get to that point? So this is the strategy we're using. We're asking a clinical question. We're trying to gather or have evidence resources readily available. We're completing the search using those resources, for example, PubMed, CINAHL, Cochrane, any of those valid resources, sources of valid information. We're going to examine the results of the search, and then we're going to apply the findings to the individual patient. So everything that you're learning in grad school, you're going to find is we just keep giving you these systematic approaches of dealing with things. You know, it's hard to memorize each systematic approach, but just realize that these systematic approaches exist and they are there for your benefit and your resource to help guide your clinical care. You know, sometimes you're going to find you're so overwhelmed with certain things. These little strategies to approach things actually make things much, much easier to deal with sometimes, especially when you first graduate. So we're building the evidence for practice. So where does that come from? We have the National Institute for Nursing Research, which aligns with other nursing institutes to help develop funding for nursing research. And then, of course, there's combinations of methods, scientific method, and many methods of knowing. So another thing I wanted to point out for you in your readings that I thought was really, really helpful on page 62 of your chapter, of this chapter, chapter 5, there's a text box 5.3. Please read that box. Also on page 69, that was the box I really wanted to tell you. Box 5.5 on page 69, it has the framework for evaluating health literature. And it actually gives you examples of where you can find clinical practice guidelines and evidence-based guidelines for each particular published organization and agency. There's a bunch of them out there. So depending on what area of practice you're in, this is actually very, very helpful to know where to find particular practice guidelines. So for instance, the Alzheimer's Association has a guideline for Alzheimer's disease management. If you work in a facility with Alzheimer's patients, you need to know these guidelines. So go do yourself a favor, go to that website, download those guidelines, and make sure everybody in your practice has access to them and knows what the standards of care are. Or for instance, if you work in a pulmonary office or an allergy type practice, you're going to want to visit the American Academy of Allergy, Asthma, and Immunology to make sure you have the practice parameter updates, and they list the website there for you. Or for instance, if you work in a pediatric office, you want to make sure that you know what the practice guidelines are for identifying and preventing obesity in childhood. So what are those guidelines? You need to go to the National Association of Pediatric Nurse Practitioners and download them. Okay, so again, grad school is all about finding out all the information that's out there, knowing where to find it, how to access it, and what's actually reputable. And we are giving you those resources. So page 62, box 5.3, put that in your little toolbox, okay? All right, so that's it for chapter 2 and chapter 5. Hopefully these presentation was helpful. Definitely continue to read in your textbook, and I will see you on the next PowerPoint. Our next PowerPoint, we're going to be reviewing chapter 79 and 82. Thanks, guys.